Sheila,
Oi.
he is going to introduce you. Ele vai
apresentar, ok.
Ele está só esperando algumas pessoas entrarem para depois...
ok. Então, quer que tire a apresentação?
Good morning, good afternoon, good evening, everybody in different parts of the world. Today, we have a special occasion and a great learning opportunity. We have a very high-level team from Brazil. All of them, they are distinguished clinicians, professors, and researchers in the field of tinnitus. It's our great honor and pleasure to have 4 of them with us today, and we expect a lot of information to learn from them. So our first speaker is Professor Sheila Bavia. She is a professor at UFS University, Brazil, and she is member of the Neuroaudiology group of Latin America, and she is a member of the Neuroscience group. She has also background in audiology and music and cognition, and she is by profession a clinical audiologist. So we welcome Professor Sheila Bavia. Please take over.
Okay, thank you. Hello, everyone. It's my pleasure to be here at this conference. I would like to thank Dr. Alfarghal Mohamad for the invitation. It is a great challenge, but I am very happy with the opportunity. I am going to give a presentation about a theme that is based on practice and research with my current group in Brazil. I am Sheila Paiva, a professor of audiology, balance, and tinnitus researcher at Federal University in State of Sergipe, and currently I am a PhD student in Federal University at Juiz de Fora in northern state of Brazil. The state is Minas Gerais, and it is also the state where I was born. I love to research about auditory perception then, and that's why I started researching about Tanirus in research line, hearing, Tanirus, balance, and cognition. I am a member in the following research groups: the Neuroscience group, the Neurology group from Latin America, and I coordinate a study group of hearing and balance and Federal University Sergipe. In my laboratory, I care for tinnitus patients with hearing loss and without hearing loss. Some patients complain of tinnitus and they come to my group. They are people of different ages and genders, including a person in gender transition complaining of tinnitus due to hormonal self-medication. When they arrive, we take care of the whole process between diagnosis and therapy. But before the hearing assessment, it is essential to do an interview with the patient. And at this moment, the audiologist performs the interview and counseling. The interview step is very important because it gives detailed information on how the patient perceives tinnitus. In other words, the tinnitus on the patient's point of view. In this case, the audiologist asks specific questions that, along with the hearing tests, will give a more accurate diagnosis. 2 things always bother me a lot when treating the patients with tinnitus, and I felt powerless. The first thing is that the cost of a hearing aid in Brazil is high for the majority of the population. Even some people get it through the country's health system, but people with tinnitus who don't have significant hearing loss cannot get it. How can we help people with tinnitus without apparent hearing loss? In my opinion, I believe they need a different treatment. That's why I decided to go even deeper into the study of audiology neuroscience, auditory neuroscience, especially in health psychology. And I will share with you 3 points that we should discuss more. How many dimensions does tinnitus have? What is health concept? What is really tinnitus? And what is the interference of tinnitus in the functional aspects? When we check the documents of the World Health Organization, we find the following definition of health. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. We know that tinnitus patient care currently is a great challenge for these healthcare professionals. Understanding this concept helps us a lot because the biopsychosocial model has some fundamental points for professionals who treat patients with tinnitus. Sometimes, without realizing it, we put the quality of life dependent on the health condition and not interdependent of other aspects. There are some points of this model proposed by the World Health Organization that I will highlight in order to better illustrate what I mean. Patient-centered information as health predictor replace the dominant principle that every disease has an identified primary cause. Human beings are complex systems. The disease has multiple factors and not a single causative factor. Biological, psychological, and social factors are equally important for health and disease. The model highlights the relationship and not the existence of a hierarchy between aspects because everyone is equally responsible for maintaining the individual's health. The model has 3 parts. The bio is about biological factors like physical or biochemical. Psycho parts is about psychological factors like rational and emotional aspects and individual stories. And lastly, social parts like a relationship with family, friends, social norms, and social values and health. To better understand, we'll detail and exemplify this application to tinnitus. Here we have more detailed information about the aspects and how they are related to tinnitus. As you can see, the biological aspects refers to physical conditions related to tinnitus. If tinnitus is unilateral or bilateral, if the person has or no hearing loss, what is the frequency of tinnitus? If is tinnitus high or low? If it's just a sound or it's more than one sound at the same time? How long is the person noticing the tinnitus and how longer it has been getting worse? How much it bothers you in your life, among other things? The psychological aspects refer to self-perception as cognitive and behavioral skills and stress management behavior based on different beliefs, with, of coping and self-efficacy strategies that are related to thoughts and emotions, relationship with the limbic system, such as some cases of greater discomfort or somatosensory, which modulates and may benefit from manual therapy. We also know that the level of anxiety.
Professor Sheila, sorry for interruption. Can you come closer to the mic? Some audience complained the voice is little bit soft. So if you can increase the volume or just come a little closer to the mic, that will be great. Thank you.
So, it's okay? Hello, it's okay?
I am hearing. I don't know about Mona. Mona, can you tell us if you are hearing? Yeah. Okay. People. Okay.
That sounds good. We can hear.
Okay.
Maybe something wrong with Mona herself. Maybe she needs to get out and then to come back again.
Desculpa, eu não entendi, Sandra.
No. Continua.
Okay. And it's okay. And the psychological aspects, and finally, resignification of Tanirus perception or habituation in sound therapy, discomfort, perception, and negative association. And finally, the social aspects are related to existence of family support, cultural issues, skills, and acceptance of certain conditions. The social environment the patient attends are shared values and their capacity for social adjustment. And what is Tanirus? I'm still looking for answer, but today I can share some information and thoughts with you. Tanirus involves the perception of a sound or sounds in the ear or in the head without an external source. What have the studies been talking about? Objective Tanirus is defined as the perception of a sound which as physical source generated in the ear. An external observer can perceive objective Tanirus. Subjective Tanirus does not involve an identifiable sound source, so it cannot be heard by examination. It is caused by anomalous activity in the auditory system. Most individuals who experience tinnitus have a neutral reaction to the percept. However, for some, it becomes a problem. The uncomfortable tinnitus can best be described as a negative emotional experience associated with an auditory experience, or described in terms of actual or potential physical or psychological harm. Subjective tinnitus is a complex condition of multifactorial origin and therefore heterogeneous patient profiles. In most people, tinnitus is not traceable to medical cause. Tinnitus, for the most part, cannot be measured objectively and is therefore subjective and individual. In medicine, it's considered a symptom. Any alteration of the normal perception that a person has on his own body, on the sensations, which may or may not consist of onset of illness. Remember that the difference between sign and symptom is that the symptom is perceived and reported by the patient, and the sign is what the doctor can see. Therefore, differently from the signs, the health professional cannot identify the tinnitus patients just by observing the patient's audiological exams. because he needs to check the patient's report. And for the reason, the absence of scientific evidence does not mean that this cannot happen. For example, the fact that hearing tests are normal does not mean that there is hearing loss, as we have seen in current studies. The study compared sound-modulated electroencephalography records between Tanirus patients and health controls. This research highlights some important points. In summary, the present study found out the following topics. Cortical activity in Tanirus patients is different from that in individuals without Tanirus. Changes in cortical activity included changes in the sleep record. There was a predominance of cortical activity in the temporal region. Acoustic simulation affects spontaneous cortical activity in Tanirus patients. The second study is a Brazilian study and is about a proposal of psychotic classification of persistent Tanirus. The authors made the proposal to classify persistent Tanirus in pure tone or noise, present in high frequencies or low frequencies, and highlight the importance of establishing its characteristics, aspects, and the repercussion of the symptom in the patient's life to direct treatments. A Chinese paper recently published suggests that Tanirus without hearing loss is associated with significant changes in white matter integrity. Another point highlighted is that these changes can occur regardless of duration and other clinical performance. The corpus callosum is formed by several sets of neural communication fibers. It is located in central region of the human brain, and these sets pass information from one side to the other and have very important functions such as establishing communication between two cerebral hemispheres. Remember that the right hemisphere of the brain commands the left side of the body, and left hemisphere commands the right side of the body. Axis in the interpretation of information from the senses. It also acts in the process of the interpreting mental information. This is a very interesting research. In the European guideline, the Tanirus classification is, it's acute if the patient had experienced it for less than 3 months, and it is subacute of 3 months. It's a chronic when the patient experienced it for 6 months or more. Assessing if Tanirus is acute or chronic is relevant to the correct treatments. The document has a biopsychosocial approach. The objective was to develop meaningful European guidelines based on consensus for the assessment and treatment of Tanirus patients. Now, talk about functional capacity. In order to describe functionality and disability related to health conditions, the World Health Organization created the International Classification of Functional Disability and Health, ICF, which aims to provide a standardized language and model for describing health and related states. The concepts presented introduced a new paradigm on disability and disability that came to be understood not only as consequence of health, disease conditions, but also determined by the context of the physical and social environment, by different cultural perception and attitudes towards disability, due to available service and legislation. This figure demonstrates the relationship between the dimensions of tinnitus interference in the patient's life and how the functional capacity assessment looks according to the biopsychosocial model, understanding the functional capacity more broadly involving activity, social participation, and personal and environmental factors. Functional studies refers to physical, psychological, and social factors that affect health. The interaction between these factors in any dimensions can enhance functional impairment. Several studies indicate the substantial role of psychosocial factors in development of disabilities. Self-perception is related to behavioral, affective, and physiological aspects, and physical, mental, and expectations, articulation of cognitive skills, thinking, feeling, behavior, specific protocols, for example, scales, inventories, questionnaires. Self-efficacy can be defined as the belief that people have in their ability to organize and execute actions necessary to achieve certain results, or how the individual's belief in their ability can influence motivation, persistence, vulnerability to stress and depression. A person can have a poor, adequate, or extraordinary result depending on fluctuations in how he thinks about his self-efficacy, as completing a task requires not only skills, but belief in his self-efficacy. Self-efficacy determines if the behavior will start, how much effort will be undertaken, for how long that behavior will be maintained. Maintained people tend to avoid threatening situations that they believe to overtake their coping skills, but they engage in stressful activities and behave confidently when they think they are capable of handling this situation. Self-efficacy beliefs mold the results that people hope to produce with their efforts. People with high self-efficacy expect to achieve good results, and people with low self-efficacy are easily convinced on the futility of their efforts and quickly give up trying. Individuals with high self-efficacy see the impediments untransponsible by improving self-management skills and persisting efforts and remaining the course of the actions in face of difficulties. Self-efficacy beliefs are seen as perception about the capacity to organize and execute a specific course of action. They are regarded as a central element in the foundation of motivation and attachment, and may affect the manner with individuals cope with taxing environment demands without falling into dysfunction. The individual sees environmental threats as opportunities, choosing strategies to deal with them. Using self-regulation mechanisms, the individual motivates themselves and steer themselves through proactive control, establishing challenging goals and mobilizing efforts to achieve the desired goals. Social support is essential in maintaining the individual's health. It's very important in the therapeutic proposal. It is formed by support from family, work, and in the interpersonal relationship. It is important for the development of coping strategies and the psychosocial skills. Is the support and protection network in adverse situations to maintain the individual's global functioning and for psychosocial adjustment. Psychosocial adjustment is ability to deal with Tanirus in the context of life. Among the psychosocial impacts on the people with Tanirus, we can highlight difficulties in relationship with family members, stress in the workplace, anxiety, and depression. The evaluation of the impact of Tanirus on the patient's quality of life is one of the pillars in the investigation to determine the best way to treat the patient with Tanirus. However, professionals who deal with the evaluation and treatment of Tanirus remain in doubt about how to talk to patients about the specific characteristics of the symptom and the possible treatments available, requiring greater depth in the subjective, as well as mastery over cognitive process and its psychosocial issues related to it. And finally, health is understood with different dimensions, some with a more objective character and others with a more subjective character. Psychosocial variables are therefore more important in determination of susceptibility, severity, and course of the disease than to the previous assessment. Physical and psychological factors are inseparable and interdependent. A new approach for Tanirus assessment and treatment was raised based on integrity assessment model. Thank you all for your attention. It's my contacts and I talk and thank you. I would like to thank you again for the opportunity. I am available to answer questions by email because you can see I am not fluent English speaker. This opportunity was proposed to me in an unexpected and totally surprising way, but it was a wonderful challenge to practice self-efficacy.
Thank you very much, Professor Sheila. You did a great job, and that's a wonderful presentation, but we will postpone the questions. I do have a couple of questions for you myself, so just postpone after the second lecture. So now our next speaker is Dr. Andrea Azevedo. She's consultant otolaryngology, and she's a member of the Tinnitus Pharma Group of Tinnitus Research Initiative. She is MD, consultant of otolaryngology, and also at the same time holds a PhD, and she is a distinguished researcher and a clinician. So please, Dr. Andrea, take over.
Thank you, Dr. Alfarghal. Welcome, everyone. I hope everyone is fine and safe. Today, I'm going to talk a little bit about some aspects psychological aspects of tinnitus. And as we told in the beginning, we worked with tinnitus about 15 years. And what I learned from all that time is that empathy is a feeling that we that work with tinnitus patients must have. We need to care about patients, to make him feel comfortable, to understand this feeling. Otherwise, the treatment starts wrong, in my opinion. Today, we have many pathways to do, as you can see here in this flow chart that we have done in 2010 by TRI that shows a lot of ways that you can do with the patients for diagnosis, for counseling, for treatment. We didn't have these all of these choice before, and now I think we are very lucky to have. We cannot say anymore that we don't have anything to do because we have a lot. I was in the time that the doctor used to tell the patient to turn on a radio or TV to sleep, and that it was very frustrating for the patient as it was for us. So when it's very common, the patients go to our office and he sit in front of us and he tell us that at night the tinnitus get worse, get louder, and we can hear that, but sometimes we don't really feel what he feels, and that's very important us to feel. So I was watching a movie and I saw a brief part of this movie that called The Hunter, and it just inspired me to show to you, and maybe we can see a little bit about what happened with them at night. It's terrible. And well, we know Sheila talk about the tinnitus. She defined it very well, but I will just remind a little bit some things that you can perceive it in head or ears. It can be ringing, hissing, or a whistle. Most of the time, it's subjective, and 5% are catastrophic. Today, I think I will talk a lot about this catastrophic tinnitus. They most of the time it comes with sleep disorders, hard concentrating, anxiety, depression, and etc. Anxiety and depression are predictive for tinnitus severity, and there is evidence of neurotic traits in tinnitus patients, especially severity ones. There are two questions that hang in the air: why some individuals adapt to their tinnitus, why others do not. We really don't know. And if can the personality traits influence the impact of tinnitus? Well, all those research shows that yes, their personality traits can influence. And the outcomes that they had in common, it was the low extroversion and high neuroticism. This is a two traits that we have as personality. I will I will talk about this last one that was the most recently. It was done in Regensburg, University of Regensburg in 2019. I will just uh, remind a little bit before I talk about this research. What's personality? Personality is the thought, the feeling, and the behavior of a person, and it differs from one people to another. And psychological seeks to understand how individuals differs and how neurosubtractive and environment and genetics can be involved on it. There's something making some noise there. It's, well, I will talk about big five theory is the most acceptable measures in research. It started in 1961, and after that, there is a lot of research that began improving it. And in 92, it was relevant. It became relevant in the community. So, and all the research in several centers, different centers, they all agreed that we have five traits in our personality: agreeableness, openness, conscientiousness, extroversion, and neurosis. And in all of them, we have neurotransmitters. We have the traits that are stable in your life. If the object is harm avoidance, it is neurosis, agreeableness, and conscientiousness. And the neurotransmitters involved are serotonin, noradrenaline, and cortisol. And we have the two that change in our life. It's openness and extroversion. And the neurotransmitters involved are dopamine and opioid. So each of these personality traits, we have 6 facets for each one. And so if you use the NLPR, that's the questionnaire that I liked very much, you will say, wow, Andrea, well, it has 240 questions. And you may say, oh, that's too much. But it's so grateful when you see that the patient answered it and he feels that you will really know him because they ask everything. So it's you get to really analyze the patient and you can see all the traits. You can see what's high, what's medium, what's low, and maybe you can think about neurotransmitter, and this somehow can help you to treat patients. So I will talk a little bit about the three of the personality traits that they found that in the research that were done in tinnitus, they found that patients with catastrophic tinnitus has high neurosis. High neurosis means negative. Negative is emotional stress, anxiety, depression, anger, irritability, and panic. And neuroses come first than tinnitus. People don't develop neuroses because they have tinnitus. It's proven that people that has neuroses can have catastrophic tinnitus. So it's the major personality risk factor for psychopathology. Extroversion. Extroversion has two important aspects. Wanting and liking is they are different things. Sometimes we know people that has very much something, and when they get the things, they it doesn't matter anymore. This is uh, something is wrong there because you have to you need to have the wanting and liking, and the dopamine is responsible for wanting, and opioid system is responsible for liking. So in the tinnitus patients, they saw that they had low extroversion. So they wanted to be lonely, they are reserved, not mandatory, and unisocial. Agreeableness. Agreeableness is cooperation and outreach. There are two important aspects: it's empathy and politeness. And the neurotransmitters associated is negatively associated is testosterone levels. That means that high testosterone, low agreeableness, and oxytocin levels, it's associated with agreeableness positively. So if we have low politeness, you have more aggression. So I will talk now about the research that I meant that was done in Regensburg. They made a longitudinal study. They got 388 patients, and they followed them from 2002 to 2008. And they used the questionnaire KHI, TK, to this questionnaire, and V5 index, that is a reduced version of the new PR. And they evaluate neuroticism, extroversion, and agreeableness. They clustered them in 3 groups: better, same, and worse. This was they have the first visit and the second visit, and what they saw is that the patients that got better and were the same, or that means that they get used to their tinnitus, they had low neuroticism and high extroversion, while the patients that got worse had high degree neuroticism and low agreeableness. So they conclude that maybe the personality traits can predict the severity of the tinnitus. We have done in 2017 research with oxytocin. We tinnitus treatment with oxytocin. And I will just give a little bit of review in oxytocin. It's produced only in mammals, produced in hypothalamus and released in bloodstream. There are a research that they have done before for anxiety, that they saw that the application of nasal oxytocin reduce social anxiety. If you have high oxytocin levels, you have high oxytocin levels in people that has the trace of conscientiousness. They are responsible and just good stuff for works. And you have reduced oxytocin levels where in some disease that normally you have high dopamine levels, as compulsive disorders, autism, eating disorder, addiction, schizophrenia, and post-traumatic stress. So it has 2 action mechanisms. The central one that it acts in dopaminergic and serotonergic pathways. So it works in the behavior, in humor, increase empathy and feeling of attachment. As peripheral, we have lactation, during contraction, but what's matter for us, I think, is the regulation of endolymph and perilymph homeostasis. It acts in aquaporine receptors that are water channel proteins. It's present in the ear, vascular and endolymphatic sac. So oxytocin has similarity to vasopressin, that is an antidiuretic. We have it in kidney, and it acts in inner ear also. It binds to vasopressin receptors, so it causes antidiuresis also. The volume of endolymph and perilymph must be constant in cochlear and vestibular system. So if you have some impairment there, this can be a cause of tinnitus also. And oxytocin modulate aquaporins. It increase the expression of aquaporins in inner ear of the rats. So, and it's important for water secretion and absorption. So in our work, it was an open label. We had 15 patients. We used THI and CGI. They visit us once a week for 10 straight weeks. And the posology was 1 puff each nostril twice a day, giving a totally 16 units. So as you can see here in the CGI, it reducing significantly. And in THI score, the same, it reduced it. So we conclude that it worked. It was an open label, a very small study. Some of them told us that they had immediate effect, but we tried to see if this immediate effect was relevant, and it wasn't. We had some results, but for a longer time. So what we conclude here is the knowledge of personality traits might help us to know the traits that are more predictive of risk of psychiatric illness and catastrophic tinnitus. And the empathy is pivotal in tinnitus treatment. That's what I wanted to show you. Thank you very much.
Thank you very much, Dr. Andrea, for this very nice and informative presentation. I think now we can take a few questions. Let's to check the chat. If not, just I have two questions for Sheila and for you as well. So no questions from the audience. So my question is first, what do you think about tinnitus? Is it a disease, or it's a health condition, or it's a reflection of psychological or personality disorder? So both of you, I would like to hear your input about this.
Okay. Did you ask for me?
Both.
Yes, both of you.
Oh, okay.
Because your talks has some relation here. So the social aspects discussed by Professor Sheila is also reflected in the empathy lecture by Professor Andrea, because I think there is some relation. So we have many of our audience, they are from medical backgrounds, and I see in the chats still they're thinking from the medical perspectives about tinnitus. So it's like a disease and should has some specific drugs or a treatment. But the approach about the biophysical model presented by Professor Sheila and the personality traits and its relation to the tinnitus revealed in the lecture of Dr. Andrea, I think we need to highlight the concept about tinnitus. So for me, I believe it's not a disease, it's a health condition. Maybe this is a better definition of it. So both of you, if you have any input, or the other panelists also, they can share in this important point, because most of the negative counseling or the bad management comes from that. Sometimes people insist to use the medical model to address the tinnitus.
May I begin? Can I talk? Well, I think tinnitus is a symptom, and sometimes it acts like a sequel.
Syndrome.
Sequel. Sequela. How do you say sequela?
Sequela complication. Like a complication.
Yes, sometimes it comes to change everything, and there is the importance of, we know, neurotransmitters, and it's hard to know which neurotransmitter is high or low, or what's really happening. That's why I believe in associated symptoms. I think the associated symptoms help us a lot to deal with the tinnitus patient. And well, what do you think, Sheila?
We have, I think, Sheila, you want to say something?
I don't speak English fluent.
No problem. Your colleagues can translate if you have any.
Sandra, você pode traduzir para mim?
Okay, yeah, you tell you and I translate, yes.
Ele perguntou o que eu acho dessa questão da
O zumbido é doença, é uma condição de saúde, é um sintoma, o que que é?
Então, de acordo com a minha apresentação, eu encaro, é um sintoma que é uma condição de saúde, e ela só não é, dentro da proposta, ela é um sintoma, mas que pode estar associado a outras condições de saúde.
Okay, let's go for parts. Okay, she believes in some cases it is a symptom, but if it is related to other conditions, it can be considered as a health condition.
Perfect. So second question also, I think it is important. So both lectures talked about the social and psychological support. So what do you think about the online tinnitus support groups? Do you recommend, do you think this is alternative for the family support or support from significant ones or no? What's your view about the so many tinnitus online support groups in different countries?
Well, are you talking about therapeutic counseling, or are you talking about those groups that the tinnitus person made?
Yes.
Which one?
Tinnitus patients made, those made by patients.
Well, I have seen good things. They change some experience, but sometimes I think they just put themselves down, and some of them just take the hope of others out. And I already tried to participate in some of groups to help, and I just got out because it's hard to help them. You know, you have their all personality traits, and there are some people that will like, but there are some people that just don't like you, don't like people that treat tinnitus, that treat tinnitus. And it's very hard. It's hard group to get in. I didn't have a good experience with it. I don't know about Sheila or Sandra, but I didn't have.
No, I never worked with group doing therapy, just individual, just person by person.
I think it's better.
Sandra, I'm talking about, you know, like support groups made by patients for patients. Not by professionals.
Not the professionals. No, I think as you look to the psychological way, they believe this is good because you learn, people will learn how to deal with their problems, listening other people's problems. So when you hear, I'm not really sure if I read this, but I hear from professionals that they say this is a very good like condition or like situation that you can put those patients to be in, and in the majority of cases I think this is good for them. But as Sheila and Andrea said, you might have someone of them that, or a couple of them that are not going to because if they don't learn to cope with their teams by themselves, sometimes they don't like want to listen, and they get like worse listening others people's problems. So I think it depends. Maybe the answer is depends of whom we are talking about. So it might be the best answer.
Thank you. So I think audience got interested, Dr. Andrea, by even me, first time to hear about oxytocin use for personality trait disorders and its role in tinnitus. And I think audience, they want to hear more about this kind of treatment. We know oxytocin, it's used in OB-GYN and obstetrics to enhance natural contractions of the uterus or to prevent postpartum hemorrhage. So it's new for us to know the benefits of oxytocin for personality traits and for tinnitus. So audience, they are asking if you can highlight more about this kind of treatment, and if it's already in the clinical practice or just a research.
Yes, we have done a research in 2017, and it's a very hard to find this oxytocin spray here in Brazil. So we want very much to do more research. It's necessary. Our results were very good, but it's hard to find it here. When we did the research, I had to go to São Paulo to buy some, because it's not easy to find, at least here in Brazil. I don't know in your country it's easy. And today it's harder to find. That's why we couldn't go along with it. We couldn't do it anymore. It's like
It is an injection form in our country.
no, we use no, we have injection also, but it's would be a more hard to do it. We use the nasal one, the spray.
I am not aware. It's the first time for me to hear about it. Anyhow, that's interesting area of research. Keep on, and please update us if your research progressed more in this area, because sure, everybody looking for the magic medication which can help with tinnitus. So our next speaker is Professor Sandra Bastos. She is the Chief Executive Officer of the Sandra Bastos Otolaryngology Institute. She is a member of the International Conference on Hyperacusis and Tinnitus Committee, and she's a member of the International Clinical Expert Group in Cognitive Behavioral Therapy. So welcome, Professor Sandra, please.
Thank you. Can you see my presentation? Are you seeing?
No.
Nope.
Yes.
Now yes, right?
Yes.
We are not going to have the break. He said that after discussions we are going to have the break. We go straight, Dr. Mohamad.
Let's to go on.
Okay, I want to thank as well to Dr. Mohamad for the invitation and for the excellent like idea to make these online meetings. And I think this pandemic is going to give us this present to bring all the world all together. So we feel more closer one to another. So just to let you know a little bit about myself, I am my ENT doctor, as Dr. Mohamad just said, and I'm very glad to share with you some brands that I've been building, or I can say that I built up so far in the last few years. And starting with a little story that happened to me, or a situation, a moment that it passes to me a few weeks ago when I was recording a podcast with a friend about hyperacusis. She asked me to define tinnitus in 2 words, and I said to her, I answered her that suffering and possibilities, I think, is the best words that can find tinnitus in my perspective. And this is what we are going to talk about today in my talk. So moving a little bit further, talking about tinnitus, I'm going to talk especially about those patients that maybe we can define them as like a health conditions problem, right? Not just a symptom, as Dr. Mohamad asked us to define it in our perspective. So we are going to talk about those people that have tinnitus as intrusive symptom. So their lives are absolutely compromised about the symptom itself, but lots of things are going on in the same way. So we can look to this group of patients, and I want you to look to this topic and understand that the three are linked together, and they activate one in another. So they are, and I want you to understand these factors as areas of the brain at the same time. So we are talking about auditory perception, emotional response, and attention and awareness. So these three topics, they work in a vicious circle that compromise the patients, as we are going to see and we're going to discuss in the following slides. Oops. All right. So to understand what we are talking about when we talk activation in tinnitus, in talking about the network that happens in the central system. So I always say that patients would be, tinnitus patients would be very easy to be treated if only the auditory system would be accommodated or involved in tinnitus. But we can say so that maybe those patients are the easiest ones to follow and to treat. But the complexity of tinnitus patients become when we understand that there are no auditory areas in the brain that are activated in the same time. So as much as those areas, the non-auditory areas, are activated, as you can see here as attentional and the whole limbic system in the same time, as much as those areas are activated, as much complex and difficult those patients are going to be. Okay, so so we need to understand that this is like tinnitus is like a dysfunctional problem. There are some alterations in the structure of the brain, and it reflects in how patients are going to act or behave. All right. So having a look in exactly in those non-auditory area, I want you to understand not these areas just as psychological or anything that is related just to attention, but as Sheila and especially Andrea mentioned before, those areas are related to personality. So and build this in your mind, that this is how the person is. So imagine some areas of the brain activated, and this is going to be holding how the person is, and adding something or an activation, a stimulus that is interfering, is modifying how that person actually is. All right, so imagine the personality, the wishes, the choices, the decision making, and so all those factors are activated in those areas. So coming back to those topics that I mentioned before, when we say when we talk about distressing tinnitus patients, they correspond to 1 to 5% of the whole amount of those patients. So we think that's all. It might be a few patients, but it's already a lot. So this I'm not not considering how important are those that are not bothered that much as with tinnitus. But we have to consider and to give more attention to those that don't know or don't not know, but exactly get the simple idea of how to cope or not to perceive or not to be bothered with that symptom. And we could think that as soon as those topics are related one to another, we could think that, okay, let's, if the easiest way is to treat the physical part of the tinnitus, that there is something is wrong in the auditory via, we could think, okay, if we repair this part, as a consequence, all those other parts would be like solved in the same time. But this is not a wrong, this is a wrong understanding. So when we talk about those topics, we talk, I want you to have in mind that is like that something is wrong with the auditory via, something is why those patients pay attention so hard, why that area of attention is so highly activated, and in which whom. So as Andrea said, I'm going to repeat, in which personality. So we can understand that these three areas are linked, they are connected in those patients, but if you want to work on them, they are going to be treated in each one of those areas in a specific way, right? And I want just to mention something about loudness, because it's that you may think that, okay, let's treat the auditory via, and as a consequence we are going to have anything better and solved about the loudness, and it's not that easy. So those patients are very challenging for us. So if we really want to change and to modify and to make those patients cope or decrease the irritability related to their symptoms, we need to give them a more specific approach. And we could say that this approach is a psychological one. But again, I don't want you to think that those patients are, they are psychologically compromised, but don't stamp them, don't give them oh my goodness, like I forgot the name in English, but don't rotulate them as a psychological one. Otherwise, you might get some problems. So understand that that area is activated in a wrong way in that patient. So you need to give an understanding about this. Okay. So what we can understand that is more moving a little bit further in our understanding so far. So why those patients perceive and interpret that symptom as something that's not good? Okay, maybe we could think, okay, make the link as a good thing. We might ask that's so much, but they could at least think that is not that much, as actually the majority of patients actually do. So in those patients, they perceive it as something that is disturbing their lives. Okay, so I want you just to increase like the knowledge is not only about our awareness. So the attention is absolutely strongly activated, but to understand and to get closer to this understanding is actually the meaning of this noise in that patient. and in which home it is working on. So before we talk specifically about CBT, that is actually what I want to talk about. I think we need to have in mind that it's not only CBT that patients really needs. Before that, I would say that like 100% of patients will need the tinnitus education. They need to learn. They need to know what is really going on with them. Okay, so we have this word that we can the counseling word that we can that came from Jastreboff, like almost 30 years ago, when he introduced the TRT treatment. And but I think I understand this like counseling and even the tinnitus education as a step that cannot be forget. Otherwise you are going to like work in someone that it doesn't know that, or will never understand what you are doing with them. Okay, so the literature brings that this is very important for the patients, but there is not any single there is no like paper or study that worked just with counseling or just with tinnitus education. So probably what they say, actually, just even if with no studies being done with those issues, they say that it might not be enough. So patients probably will need something else, even if they get the knowledge. Okay, so imagine that fear of as I wrote down here in this slide, fear of the unknown. So what patients might have just in the beginning when they are not understanding what's going on with them and what to where it's going to, this like symptom or this condition is going to take this patient to where it's how far it's going to get. Okay, so if you take out, if you try in the beginning, since in the first appointment, if you try to make them understand and decrease their fears, I think this is a very good an important step for the treatment. So when we talk specifically about CBT, we talk about change. Okay, so imagine that the way that patient is working, how that brain is working, is in a specific way. So why all those researchers are saying that CBT is one of the most important treatments that patients could be run, is because about change. Okay, and the most important part is that we are going to change the cognitive issues related to this how can I say involvement. Okay, in those particular patients. So what exactly we are going to change? One of the first steps that CBT work on is on thoughts. So imagine that when somebody think, or even us, when we think about something, we just when we think about the thought, we already thought. We already have the thought. So we are talking about that we are not in control of. So how to control and how to understand what we are thinking. Okay, so this is a very strong tool when we talk about CBT. And as a consequence, we are working as well with the emotional part of this like triangle that I'm going to show in a minute, and the behavior. Okay, so these are those the topics that CBT work on, and specifically and mainly on thoughts. Okay, and again, as a consequence, the emotions and the behavior are going to be changed. So because they are linked, they are like connected even if we didn't, even if we don't know that how it does work, it is like this. So thoughts give us our emotion. Is in everybody, okay? Is in all of us. This is how our consciousness, or we can say unconsciousness actually, works. And after we feel something or we have any emotion, we just we just develop our behavior. So at the same time, we could look to CBT and see like something happening to in those patients' life, and from those events or from those things that are happening, those patients, and we could bring this to tinnitus, all right? They think about something. So their thoughts about specifically about their tinnitus are going to be in a specific way. And as a consequence, emotion, and as a consequence of emotion, the behavior. So I brought here some examples for you to understand what I'm talking about. So let's take two patients as an example. One that is coping badly in not understanding what tinnitus is about. What is this that I have? And another one that is let's say is ahead. Okay, is ahead in knowledge. Okay, and even worked already. So we can, you might see, you might remember some of your patients when I read these examples here. So what we are going to find as thoughts in those patients that doesn't cope very or not at all with tinnitus. They think there might be something wrong with my hearing, or they think it will get worse by the time. I won't be able to concentrate and I will have to stop working. Okay, so they often, I will correct, they all the time they bring negative thoughts. Okay, and those negative thoughts, again, they are automatic. They are without of our control. Okay, and as a consequence of the thoughts, what they are going to get: anxiety, body tension, increase of tinnitus. They could like focus on tinnitus or take time off work. So they compromise their lives, okay, because of, we could say, in the beginning it was a symptom, but how much this symptom is compromising those patients, and we can understand that is like disturbing that much, okay? And look at this other example that this patient is coping or trying to minimize the problem. He would say, my tinnitus is quite annoying this week, but I know it is not dangerous. Or he might say, I am stressed at the moment, and I know tinnitus gets worse when I am like this. So it's more like comfortable thoughts. They are more, they are positive. Even if they see something wrong with tinnitus, they compensate. They bring up, they come up with a positive thoughts that make the tinnitus not that bad. And as a consequence of their thoughts, what those patients are going to get, not very much change in like emotional or physical or even in their attention, or in this example here that he he's understanding about himself. What he might say, take action to reduce the stress level. So I want you to understand that as when you work with CBT, you are giving the patients not just knowledge, but you are giving self-knowledge. Okay, so they are going to understand how they really work. Oops. Okay, and what does CBT give the patients. What is the aim? What's the goal? What we are going to get? There are some topics here, and I'm going to say is more or less like guaranteed. Okay, not for everybody, but but almost 100 of patients they improve at least a bit. Okay, they eliminate suffering, they alleviate the stress, improved quality of life, but they are not related to how loudness are going to react. So, and it's not a promise of cure. Okay, so is a technique, is a treatment that gives the patient skills to how to deal with their tinnitus. Okay, and as I said in one of the first slides, when we are working with how to cope and with the stress itself related to tinnitus, we are not working with loudness at all. Okay. So the main thing about CBT is a change in cognition. Okay, this is the key. This is like the important part of CBT. And as I was saying, there are some articles that says that people can, after CBT, can be good with their tinnitus for over than 15 years. On my experiences, because I'm doing, actually, I was trained in England by Dr. Hashia Shah Azhar, and I feel like myself as able as a professional to work with CBT on tinnitus patients, and what I get is absolutely an improvement in the quality of life, in how they cope with their tinnitus. And even if their tinnitus is not low, it's loud, it's very loud, they don't care. They just keep falling in their lives. So there are some examples. When we do and we work on CBT, we call the real practice as formulation. And I put some two actually examples of how you can work on those patients, because they need to see. Okay, they need to see what you are seeing, and they need to see and even listen to what they are saying. Okay, so when you write it down in some way that we call the psychological field call as formulation, it can be like this. This is a work of Lawrence McKenna, that is a psychotherapist in England, and this is the formulation of Hashia Azhar from England as well. And if I mention Hilana Sima, that is a psychotherapist in the Netherlands, she uses the fear avoidance model. So she uses the idea of, as I said before, imagine if you don't understand what is going on with you, the first thing that is going to happen is fear related to that condition. Okay, so this fear avoidance model is not just specific for tinnitus, but it is used as well for chronic pain and for psychological conditions. So, and if those people doesn't improve, okay, what we can do for them? How can we seeing something to be done? Because as I said in the first slide, we have many options. Okay, the possibilities to treat tinnitus patients are many. And but I'm with the literature that CBT is one of the most, or maybe the most strong, the strongest tool that we have so far. So, but even being like this, there are some people that don't respond as we could expect in the first place, in the first moment. So they could go through a mindfulness-based therapy or acceptance-based therapy. And when I say this, I don't want you to understand that the acceptance The accepted based therapy is the same as you have to learn to live with it, because it's not, okay? Imagine that the learn to live with it is like, I cannot help you, go with your life, and I'm out of it. It's something like that. So there is no commitment of the professional with the patient, but the acceptance is the understanding that life is not all good. We have like difficulties, we have like bad situations that happens to us, and sometimes that is the reality. So how to cope with the reality, okay, is something more related to it. So is that for the majority of time, CBT, even if being seen as the strongest or one of the strongest, it might be like we could discuss this later, but usually patients, they accept more CBT approach when you give something else to them, okay? And it could be, as I said, the acceptance-based approach, or even mindfulness. And the most commonly used therapy running together is the sound therapy. Okay, so what we need to have in mind, that he needs to feel and to understand that you care about them. Okay, you are like you are worried with them, and that you want them to improve, and anything that they say must be judged. So you need to listen and to interpret what they're saying, and give them like a solution, okay? And people need to be engaged and committed with the professional, okay? And as I said in one of my first slides, is one of the core or the core of the problem of tinnitus, I would say, is the meaning, okay? So when we apply CBT on those patients, we are trying to reframe it. We are trying to change that meaning, okay? In this meaning, you can understand that it is linked with something that we call the core beliefs. And the core beliefs could be understood as the self-understanding of that person. And this slide is not answering what Dr. Mohamad asked in the discussion time, but we could say that what literature brings to us, that there is no difference if the CBT is applied face-to-face, individual or in group, in self-help book. Even if patients read about self-help, they can improve, or audiologist guided internet-based services. So in any way that you try to use this technique, the result is going to be the benefit of the patient, okay? And what we are seeing as much as time goes by, is that CBT is not only something that belongs to psychotherapists or even to psychiatric medical doctors, but this is it is going to the field of the audiologists, and why not even to the ENT doctors. All right. And I'm getting to the end. As we discussed before, I just want to invite you. This was the meeting that I made this year before the pandemic started here in Brazil, and this was my second Zoom video summit. That it means Tinnitus Summit, and probably for next year this is going to be online or maybe presential and online as well. I'm working I don't have you the full answer to it yet, but I'm very interested of like having discussion. And as I have the opportunity to know you, Dr. Mohamad, you are already invited to join me in this meeting as soon as I have the date for next year in all of you, of course. And my final message is, if you change your mindset, if you change the mindset of the patients with the activity technique, you are going to have like new results. You are going to have like we can say like a new person in front of you that can that person. You give like a perspective for good things in their lives, and even with the tinnitus. Okay, even if they still having the tinnitus, but they coping with the symptom, they can like have joy, they can have like fun, and they can like enjoy their lives. Thank you very much.
Thank you very much, Dr. Sandra. It's really excellent presentation. And I do admire that you are a very well-trained and expert surgeon, but you are advocate to the cognitive behavioral therapy with tinnitus. This is amazing. 3 of our speakers, they are ENT surgeons. They do surgeries on daily practice, but because they have a more flow of tinnitus patients, they got special training, and they have been motivated to know more and to learn more and to provide a very highly professional services. I congratulate you really for this combination. That is, you are a practicing ENT surgeon and a tinnitus professional who can provide high quality cognitive behavioral therapy. It's clear that you digest the cognitive behavioral therapy very well. Congratulations, Dr. Sandra. And we'll go to for our next speakers, then we'll have some time for the questions. We have good questions, and I think we have interesting discussion. So our next speaker is Dr. Ricardo Figger. He is a otolaryngologist. He's a consultant of otolaryngology. He holds MD, master degree, and PhD. He's a adjunct professor at the Faculty of Medicine, Rio de Janeiro, and he's a member of the Tinnitus Research Initiative Committee. He will be talking about the pharmacotherapy. We have many questions came in the chat, that is asking about the pharmacotherapy. So please, Dr. Ricardo, join. Take over.
Where is? Thank you, Dr. Alfarghal. Some background noise. I can't see my video.
Yeah, I can see.
Yeah, I can see it here. Oh. No, that's not me. I can't see my video. Are you seeing my video?
Yes, yes,
Okay.
perfect.
Okay, no problems.
No, you press in the Zoom button, Ricardo. Then you can.
But
have you pressed?
Yes. Don't know what's happening. Everything was fine until now, but I don't know why my video is not here. You are here, but not me. I don't know why. Okay, but if you are all seeing me, that's okay. Thank you, Dr. Alfarghal, for this invitation, and I congratulate you for creating this amazing group. It's a very interesting initiative and I hope it will go bigger and bigger. So I will try to share with you some of our experience on pharmacotherapy of tinnitus. And when I say we, I say Dr. Andrea Azevedo and I, we have been researching on this field for the last 16 years, and I'll try to share some of our experience. If we talk about the pharmacotherapy of tinnitus, we are talking about two sides of the same coin. On one hand, there is no FDA-approved drug to treat tinnitus as of yet. And the last American Academy of Otolaryngology guideline from 2014 does not recommend drugs to treat tinnitus. On the other hand, we have this article from three of the greatest tinnitus research in the world, Dr. Bertold Langut, Dr. Richard Salvi, Dr. Anna Belén Elgoyen. And they conclude the article, say that concerning the fields of neuroanatomophysiciology and biochemistry, there is no reason to ascertain that tinnitus could not be pharmacologically treated. Here is the American Academy guideline. As you can see here, there is a recommendation against drugs to treat tinnitus and also for medical supplements. We have this Europe review from 2017, and they admit that specific psychiatric conditions could be treated with drugs, but not exactly for tinnitus. This is our Brazilian consensus from 2018. It's not exactly a guideline, it's a comprehensive view of tinnitus from Brazilian specialists. And this is an open access article, and we have many points about tinnitus treatment with drugs and also other kinds of treatment. This is a very recent article from Dr. Tanirus Sanchez. She is one of the biggest tinnitus research here in Brazil. And she analyzed a series of 80 patients with tinnitus complete remission. And the most frequent type of treatment that led to tinnitus remission was pharmacotherapy, 30% of the patients. So I really believe tinnitus can be treated with drugs. So why does it not always work? We have to look at the way the trials are done. We may have different samples, so some studies' results may not be replicated by other centers because of different populations, different methodologies in what concerns statistical analysis or the way tinnitus is measured. We have the question, and this is probably the most important question, the question of the subgroups. We have to look at subgroup, subtype tinnitus, because we have many different tinnitus, many subgroups. And if one drug is specifically good for one subgroup, and if you don't look at that when you make your sample, you will probably have not so good results. We have the question of drugs dosages. You must remember that these drugs, they act at the central nervous system, so we have to achieve efficient and safe dosage. We have the question of the duration of treatment, and we have the question of the side effects. So if you look at the brain, and the brain will be somewhat of our main targets. We have the brain, and we have the areas that are related to tinnitus pathophysiology, and we have the pool of drugs that are supposed to act in those brain areas. So we have to choose one drug for this pool, and we have to deliver the drug in the right amount to the area we desire. So that's the question, that's the problem. It's a question of the key and key lock. That's what we have for tinnitus therapy. One point that may be a very interesting approach in the future is if we use a special technology to deliver the drugs to the right place in the right amount, deliver the right drug to the right place in the right amount. If we think about functional imaging, we may find the hyperactivity areas, and we may use, for example, the nanorobots to deliver the drugs in the right amount without going to other areas of the brain that this drug will not be desirable. So it's a possibility, okay? And how the drugs should work. I used to classify the drug's action mechanisms for tinnitus in 3 types. So we have drugs that act at the inner ear vascular and metabolic supply. So we are talking here about very early tinnitus. We are talking here before the whole neuroplasticity thing is already installed. So we may try to lower what's the so-called deafferentation and stopping those neuroplasticity changes to happen. So these are for very early tinnitus. And when the neuroplasticity changes are already installed, we may talk about ion channels and neurotransmitters, because if we have the deafferentations, we will have an overexpression of excitatory synapses and excitatory ion channels. So we may act at those areas, okay? This is a picture of the neurotransmitters distribution in the inner ear. So we have the medial efferences here. We are talking about acetylcholine and GABA. They are inhibitory at those points. And we have the lateral efferents. And we are talking about also acetylcholine. Here it is excitatory. These are nicotinic receptors. And we have the GABA and dopamine and opioids that are inhibitory at those points. And we talk about the central auditory system, the thing becomes more and more complex because we have excitatory neurotransmitters. The main one is glutamate. We have the inhibitory ones, GABA and glycine. And we have those that are modulatory. They modulate the activity, like acetylcholine. Acetylcholine mainly have top-down inhibitory effects, and we have dopamine that may be inhibitory or excitatory, for example, at the thalamus. We have serotonin. Serotonin action depends on the receptors, and for example, the 5-HT2 is an excitatory receptor. Most of the other ones are inhibitory, and we have also the opioids. So these are the modulatory neurotransmitters. So having that in mind, I would try to start talking about our perspective here, because I will talk about the drugs that we have available in our markets. Thinking about the vascular and metabolic supply, those drugs that we may use in the very early tinnitus up to 1 or 2 years tinnitus, we have first the Trimethazine. It's an old drug that is used mainly in cardiology to treat ischemic conditions as an adjuvant therapy. And this drug was disrecommended by the European Agency for Tinnitus. I'll talk a little more about that in the next slide. We have the Jinko Biloba. A systematic review was not able to find evidence of efficacy. We have vinpocetine. This we don't have a proper trial on that. We analyzed vinpocetine in our TRI Pharma group trials, and it works for some patients sometimes. And we have beta-histine mainly in conditions that are associated with posterior inner ear disease. So this is about trimethazine. This was the very first paper we published about that, unfortunately only in Portuguese language. This was back in 2004, and this was an open study. But we had very interesting results. As you can see here, 90% of the patients had some degree of improvement considering a visual analog scale. And then there is this is a very recent article, and it was a randomized double-blind study on Trimethazine, and it didn't find good results. But if you take a look at tinnitus duration for the drug group, it's about 6 years. So we may say that probably these weren't the best candidates for this drug. It should work better in early tinnitus. This recommendation by the European agents is mainly based on this lack of results and possible side effects. My personal experience, this is a relatively safe drug. We don't see much side effects with it. And sometimes I still use it in very early tinnitus. This is Jinko Biloba and the systematic review that was not able to find results to recommend the drug. But I still use it sometimes for early tinnitus, 120 milligrams twice a day, and sometimes it works. The question here is that we must have a good extract, because if there is not a good extract, so the possibility of success is lower. About beta-histine, there are some papers about the use of beta-histine to treat tinnitus. Most of the times it will work only if the patient complains also of dizziness, so this may work. Some case you can see this is an audiogram from a real patient of mine, and this was a woman and she had only tinnitus. Her only complaint was tinnitus. She had no dizziness, no aural fullness, and this low frequency hearing loss at the left ear. So I treated her with beta-histine, 24 milligrams 3 times a day, and she got relief of her tinnitus. So we may be talking about some cochlear mania, and in this case, the drug may be helpful. If there is no dizziness, no aural fullness, or no low frequency hearing loss, probably beta-histine won't work. Talking about ion channels, we talk about sodium. And we have the example of lidocaine. Lidocaine, for me, I am an enthusiast on pharmacological treatment of tinnitus. Lidocaine is the living proof that it must be possible to treat tinnitus with drug, because many patients have a relief when lidocaine is used, but unfortunately, we have no clinical application because we cannot treat patients with lidocaine. The effect is ephemeral, and we cannot treat them with lidocaine. We cannot give a lidocaine injection periodically to these patients because of side effects. So what they did in past was to perform a lidocaine test, and if it is positive, if patient gets better, so they began with anticonvulsants, mainly carbamazepine or lamotrigine, for example. A systematic review found no evidence of relief with carbamazepine. I personally do not use carbamazepine because I think the results are not so good, and it has many side effects, and we have to look at the liver function and the kidney functions, complicated drugs. But that's my opinion, of course. And if you look at calcium, we may have gabapentin. Gabapentin is a drug used to treat neuropathic pain, and there are about 5 randomized trials with gabapentin for tinnitus. And these trials were analyzed in a systematic review that concluded that data is insufficient to recommend gabapentin. There is one study from Dr. Carol Bauer in the US, and a subgroup of noise exposure caused tinnitus had better results. So we may think about gabapentin for those patients. Of course, gabapentin is not only a calcium channel blocker, it has some GABA activity, but they believe that the main action mechanism is probably the blockage of calcium channels. Another calcium channel blocker is nimodipine. The data is scarce, but we also analyzed nimodipine in our small TRI pharma group trials, and we didn't find usefulness for nimodipine. And if you think about glutamate, lots of research in animals models have been done with glutamate, NMDA receptors blockers, and we have the memantine, which is a drug used for Alzheimer's disease. And animal studies data were not confirmed in clinical studies. That's a study we did in 2008, and we didn't find results, but there was some evidence that the drug should be used for longer periods, more than 3 months treatment. And I still use this drug. We use this drug if is in very early tinnitus, we may use, considering the excitotoxicity theory. And we may also use if the patient has some degree of cognitive impairment. And I do sometimes use it when tinnitus is associated with sudden sensorineural hearing loss. And I have some interesting results concerning tinnitus. If we talk about GABA, we may take a look at the benzodiazepines, and a systematic review was also done. And there are some evidence of efficacy for clonazepam in the very low dosage of 0.5 milligrams once a day. It is very interesting. It's a drug that is widely available, and it's a cheap drug. It's very easy to find, very easy to prescribe. And I prefer using the drops formulation because it is easier to take it off. I usually gave it for 3 months at least, and then I started to take 1 drop at a week, 1 drop in 15 days until the patient is free of it. It's very interesting to use the drops formulations. And also the baclofen, which is a GABA B receptors agonist. It has many animal studies evidence, but these were not confirmed by clinical studies as of yet. And we have this one, this is vigabatrin. It's a very interesting action mechanism, a GABA transaminase inhibitor. It is used as anticonvulsant. What? Oh. Where? Yeah. Okay. Okay.
Okay.
That's okay.
Go on.
Okay.
Ricardo.
Sorry, I don't know what.
No, it's fine.
Okay, so vigabatrin is an anticonvulsant drug. And there was an animal study from Dr. Carol Bauer and Dr. Brozowski in the US with very interesting results. But this is a very complicated drug to use because of the side effects. Visual side effects are very common. 1/3 of the patients have serious visual disturbance, so the drug has not been tested in clinical studies as of yet. Talking about serotonin, there was a systematic review on antidepressants on tinnitus, and it found that antidepressants are not effective to treat tinnitus. I personally do not use them. When I think that patient needs antidepressants, I send them to the psychiatrist. But I have many colleagues here in Brazil that use systematically the antidepressants. We have to think that some of them, especially the tricyclics and bupropion, they frequently cause or worsen tinnitus. When I see a patient with tinnitus that is on use of this kind of drugs, I usually send a letter to the psychiatrist recommending, if possible, to suspend or change the drug, okay? And we have cyclobenzoprine. Of course, cyclobenzoprine has many action mechanisms, not just serotonin. It is a 5-HT2 blocker. It is also, it has some activity in the adrenergic pathways and also in histaminic pathways. But the action mechanism that came to our attention in our VRI pharma group was the 5-HT2 blockage. So we performed 2 open studies. And the 2 open studies, one was done here in Brazil by Dr. Cláudia Coelho, the other one was done in Belgium by the group of Dr. De Ridder. And there were very interesting results with the dosage of 30 milligrams a day, 10 milligrams, 3 times a day. It's a very high dosage. Drowsiness is often too much. Not every patient is able to carry on with that dosage, but we may start with lower dosage, and some patients improve with lower dosage. The question is that if we may think to use cyclobenzaprine in somatosensorial tinnitus, it should work better because it is a central acting muscle relaxant. But Cláudia Coelho says that this is not true. The drug may act in all the types of tinnitus. One interesting thing about cyclobenzaprine is that the clinical studies were done prior to the animal studies. We did the open study, it's a very old drug, and then after there was an animal study that also showed benefits. Melatonin is here, but it is not a drug, of course. It is a supplement of a natural sleep hormone. And it's very interesting because we know that sleep disorders are very often related to tinnitus. So if the main complaint of patient is that he can't sleep because of tinnitus, so melatonin may be a very interesting option. And there was a systematic review on this, and it concluded that it may help some patients. The mostly frequent used dosage is 3 milligrams a day, but it's no problem if you use it higher, 5 milligrams, for example. So what I try to do in this slide is to summarize some type some kind of subtyping to guide the drugs you will use. So if we have recent tinnitus, up to 2 years tinnitus, Jinko Biloba or even Trimethazine may work. If we have dizziness or aural fullness or low frequency hearing loss, beta-histine may help. If we have somatosensorial tinnitus, cyclobenzaprine may help. If we have cognitive impairment, we may think about memantine. If we have tinnitus related to noise exposure, gabapentin or memantine may help. If insomnia is a relevant factor, melatonin may help. And in general, if the patient has not used it as yet, clonazepam may help. So I will take a brief talk on drugs that we use it to have here, but we don't have anymore. So we have acamprosate. Acamprosate, it is a anti-alcoholic drug, and it has a dual action mechanism. It is an NMDA blocker and GABAergic drug. And this, we did the first study on acamprosate back in 2005. It was a controlled, a randomized, double-blind controlled study, and we had very interesting results. But unfortunately, the drug went out of the market here in Brazil very soon after, and we couldn't make further evaluations. And then came another study from India with very similar results. This graphic shows the results of our study. So you can see here that the red is the acamprosate VAS scores compared to placebo VAS scores, and the difference was very significant. The drug is available at US and Europe and in most Asia countries and some South America countries also. And one very interesting thing about acamprosate is that Carol Bauer and Dr. Brozowski performed a study on rats with taurine supplementation with very interesting results. And why I'm talking about that? Because acamprosate is a taurine analog, so it reinforces that this may be an interesting strategy. About dopamine, I talk about piribedil because this drug was available here. It's a dopamine agonist, and this was a drug I used to. I still like it. I don't have it, but I like it. And it was discontinued here. It was an old anti-Parkinson drug, but it was no more used for Parkinson's disease. So the pharma company took it off of the market. And I remember having patients that were taking the drug for 1 month and they were getting better, and so the drug was no more available. Unfortunately, we performed a study with piribedil some time ago, and there were some interesting results in some subgroups of patients. We have the Primapexel, which is also an agonist. It is available here, but I am a little afraid of using this because it's a very complicated drug because of the side effects. Some patients develop compulsion for gambling and sex. It's a very complicated drug to use. So there is only one study from Hungary with some results in tinnitus treatment. And we have the antagonist sulpiride. But sulpiride was analyzed in Spain, three papers about it, and all of these papers associated sulpiride with other type of treatment. So it's very hard to evaluate these effects. I will make some brief comments about when the big pharma companies tried something in tinnitus, and these are the supposed flaws. Supposed because everything in tinnitus field is relative. So we have the trials here back in 2011 until 2018. These are two big pharma companies. These are small pharma companies, and you can see here that the trial stops at phase 2 or 3. So vestipitant is a neurokinin-1 receptor antagonist, and the neurokinin pathways are related to pain perception. Considering the pathophysiology analogies between tinnitus and pain, this could be a very interesting strategy. They are used as antiemetic. It's a family of drugs called the pitants. And unfortunately, Glaxo did a controlled study, and there were no results, either alone or combined with paroxetine. Then came naromexane, which is an NMDA antagonist and nicotinic receptors antagonist. This study was done by pharma company Merck. It's a German company, and it was effective in phase 2 trial, and then there were no results. We had the opportunity to participate in this trial, no results in phase 3 trial. And they came the AM101, so-called scatamine, which is an intratympanic and MDA blocker for very recent tinnitus. And this was a sort of subgrouping because they included only tinnitus that lasts less than 3 months due to acute acoustic trauma, sensory neural hearing loss, or acute otitis media. Free intratympanic dose. The results in phase 3 were positive. We were very hopeful that this could be the first drug approved by the FDA, but unfortunately, the thing stopped again at the phase 3 trial. And last came the potassium channels modulators, specifically the KV3 channels modulators. These potassium receptors, these potassium channels, they only exist at the nuclear cocci. And if we modulate these channels, we were supposed to normalize firing timing of the brainstem auditory neurons. It was a very promising therapy that unfortunately the phase 2 trial at the UK didn't come to positive results. So what we may talk about the future, this is olanzapine, which is a dopamine antagonist. And our group in TRI Pharma Group analyzed in a small study this drug. As always we do in TRI Pharma Group, we included a little group of patients. And from 15 to 12 completed the patients. This is an antipsychotic drug, but the dosage we use is not high. It's about 5 milligrams at night, and the results were interesting. As you can see here, the THI scores throughout the 12-week therapy treatment period and the 1-week washout. There were very interesting results. Later, Dr. Andrea Azevedo analyzed further this drug in her PhD thesis, and this also had many interesting results. So our plans are to perform a double-blind controlled studies with this drug. We also analyzed naltrexone, which is an opioid receptors antagonist in the dosage of 50 milligrams once a day. And we first analyzed it here. And so then the Dirk de Ridder group in Belgium also analyzed, and there were interesting results with naltrexone also. And this is a very interesting thing that was presented in the Regensburg 2018 TRI meeting. You know, the residual inhibition, which is the tinnitus remission that persists after patient is exposed to sound. And this is very useful when planning acoustical therapy. And these authors found out that the residual inhibition is linked to a metabotropic glutamate receptor mechanism. It is mediated by these receptors. The metabotropic receptors, as you can see here, are second messengers receptors in glutamatergic transmission. And so they used an agonist in rats and they found positive results. And I don't know how I didn't hear nothing about this strategy anymore, but it's very interesting for the future. And this was a 2019 study, an experimental study that linked noise exposure to neuroinflammation due to a higher expression of pro-inflammatory cytokines and microglia activation. So this leads to changes in the excitatory-inhibitory balance, and these changes in this balance may be a clue factor for tinnitus pathophysiology. So what they did is, if they blocked the expression of the tumor necrosis factor alpha, they lowered tinnitus, and if they did infusion of these factors, tinnitus gets higher. And also, if they do the pharmacological depletion of the microglia, tinnitus get lower. So this may be interesting points to act in the future. A known old drug that works here is the not good famous thalidomide, the old thalidomide. So this may be an interesting point for the future. And so we thought about probiotics. Why did we think about probiotics? Because we have the gut-brain axis that has been studied in the neuropsychiatric fields. We know that tryptophan, which is the serotonin precursor, the absorption of tryptophan depends on the integrity of the microbiota. So they started to analyze the correction of this microbiota with the probiotics to help treating depression. Then there are some good results in that field. So if it may work in depression, we thought about why cannot work on tinnitus. So we started an open study in the TRI protocol with 23 patients. And the interesting thing is that we have many dropouts. We must remember this is an open study. If patient knows what he's taking, and probably patients didn't have results or they didn't believe in the treatment, so they didn't come back. And there were very few patients that improved. But if we take a look at the THI scores and the CGI of these patients, the blue line, the results are very interesting. So we have to take a look at these responders and try to establish a subgroup of patients that may benefit for probiotics trial. This is a new strategy for the TRI group. Dr. Anna Belén Elgoyen presented this data last year in the Taipei meeting. And what they did was to look at a big data bank of side effects. This is CIDR, and this is a side effect resource. So they analyzed the side effect tinnitus, and they came to the drugs that were related to tinnitus as a side effect, and they analyzed the target of these drugs. So they came to these clusters of drugs, and we can see here there are drugs that cause tinnitus and hyperacusis alone, and hearing impairment alone, and tinnitus with hearing impairment. And the interesting is this cluster that is associated only with tinnitus, and these are the angiotensin and converting enzyme inhibitors. And this was particularly very interesting for me because my PhD thesis was about tinnitus and arterial hypertension. And I also analyzed the drugs the patients were taking to treat their arterial hypertension. And there were very interesting results concerning this type of drugs, the angiotensin converting enzyme inhibitors. And patients that were on these drugs had tinnitus more frequently. So there may be some point in there. We may look at this action mechanism to think of further drug options. And to finish my presentation, I'll talk about what we can use in somatal sounds. Of course, if we think about muscular and vascular tinnitus, we should look at the cause of these vascular and muscular anomalies and treat the cause if possible. But sometimes we may use the drugs to relieve the sound the patient is hearing, which is unlikely the other types of tinnitus. This is a real sound that the patient perceives because it is next to the cochlea. So they perceive the sound. So we may use clonazepam. We also may use the thiocalcicloside, which is a central acting muscle relaxant. And we also may think about migraine drug sumatriptan. It may also help with muscular tinnitus. And for vascular somatal sounds, if the lesion, if there is no need to make surgery, or if the lesion is inoperable. We have some reports and anecdotal reports, of course, that propranolol can help these patients when there is nothing else to do. And also, if we think about the intracranial hypertension, acetazolamide may be an option, okay? So to finish, what I would like you to take home is that it is perfectly possible to treat tinnitus with drugs. This is my belief. And I believe that subtyping tinnitus is the key to successful therapy. And we must work on that. Research should focus more and more on tinnitus subtypes, because you won't have the magic pill. You have some pills that may be magic for some patients, okay? Thank you very much.
Thank you very much, Dr. Ricardo. I congratulate you for this excellent presentation, excellent research, and great insight to add to the tinnitus management protocols. Before we go for some questions, I want to clarify that is tinnitus classified into two main categories: the somatosounds, which you pointed to in your last slides, like the vascular or myoclonic activities in the middle ear. Those are different types, and those are real sounds, and you have to find the cause and try to treat a specific treatment. And they definitely, you have to investigate very well, and to do the investigation, appropriate diagnosis, and you go to a specific treatment. Then we have the sensory neural or subjective tinnitus. And this sensory neural or subjective tinnitus can be acute, subacute, or chronic. And if it's usually secondary to a disease, such as sensory neural hearing loss or Meniere's disease, or any other ear conditions, usually we treat the disease associated with tinnitus. And Dr. Ricardo highlighted very well in his presentation. I like much the slide where you put which drug for which kind of tinnitus. I fully agree. It's a perfect slide and a perfect algorithm, and it makes a lot of sense. One more point it's important to highlight, that is lack of evidence does not mean lack of efficacy. Because for me, I don't publish a lot, but I have huge experience in management of tinnitus patients. And I will share with you some of my personal experience. But this is important to understand, that is the lack of evidence does not mean a lack of efficacy. The other thing, that is the placebo effect. Sometimes the drugs work by the placebo effect, which can be effective up to 60 or 70%. So sometimes I do use the drug. If it's a safe drug and a good placebo choice, we use just as a placebo. So I have, it was important to clarify, because some of the audience, they have really confusion. So I have one question for you and for Dr. Sandra. So my question, if you have a tinnitus patient, you start with medical treatment, or you start with cognitive behavioral therapy, or other treatment modality, based on what? The duration, the severity, or you use a combined approach? So let's start with Dr. Sandra, please.
I have to say that, actually I said before, that there is patients for everything. So CBT is not for everyone. Okay, as medication is the same, it's not for everyone. So I usually start, I offer the patients actually, I work with a menu, as I am explaining to them how tinnitus exactly work, and I offer. Okay, so there is, we have sound therapy, we have medication, we have CBT, we have relaxation, we have whatever you can like add to this menu. But it's basically this, because what I need to make like you and them to understand is we need to solve what's going on in the auditory via. Okay, if there is something wrong in the hearing, it's better to treat. I cannot go to CBT as a ENT doctor without looking to the impairment of the auditory function. So like it's mandatory for me to do something, okay? And or even if it is surgery, I don't do surgery anymore. But if I need to, if the patient like needs to go to surgery, I refer them to like a specialist. And or if they need like hearing aids or even generator sound. So it depends. At the end, it depends. So when I go to CBT, when they are after everything. So you have like as I said, you cannot start anything if the patient like you cannot like give the second step, like go to CBT if the patients or even you where you are working on. So what has wrong with this patient? So he needs to really understand how he's functioning. So and nowadays I'm taking I'm like giving too much attention for how those patients is compromised as functionality, as the cognitive area. So are them compromised to like to work, to keep working on what they need to? Are they compromised like in social conditions? But so this brings to me like how deep or how severe these patients are. I don't know if I answer you.
Yes, thank you. But let me to ask you. So do you use a combined approach? Do you prescribe medication and do cognitive behavioral therapy?
Yes, medication and usually psycho activated, as a couple of those that Ricardo mentioned in his talk. And sometimes it depends if the patient has something in the temporomandibular articulation. But I look to the patients as don't take me wrong, but as a machine. Don't take me wrong, please. But that needs to be repaired. Okay. So before anything, I need to give him functionality. This person needs to function. He needs he needs to like to take to get back to his life. So so if we look as I look to the body and as well as to the brain as a machine, as I said, that you need to leave that person functioning in a perfect way. So this is the way that I look to the patient. Okay, so so I can combine whatever you think about tinnitus patients.
One more question from the audience. What kind of outcome measures or a questionnaire for follow-up of the patient functionality you are using? What you use for outcome measures and monitoring?
The monitoring, the questionnaires,
like tinnitus, handicap inventory, THI.
Yeah, THI, the VIS scale. I validated with Dr. Tani the CALFA questionnaire, so I applied the CALFA questionnaire for hyperacusis as well, and I use the hospital anxiety depression scale, the HADS scale, and the insomnia as well, the insomnia scale as well. So I have like a scan of the patient. So I can keep following them with those, and as well, and more important, about how they describe their tinnitus and how functional they are after anything that I do to them.
Thank you very much. Dr. Ricardo,
Yes.
what's your approach? You start by medications, and when you refer a patient for cognitive behavioral therapy or other kind of therapy, sound therapy or whatever. So what is your protocol?
It depends on the patient, because there are patients their tinnitus start and they are only worried if that could be some bad thing, and they come to us and we do all the clinical evaluation, we do the necessary exams, and there is nothing bad and the patient is okay. And many of these patients, they do not require treatment because they only want to know if they have a severe disease. There are other patients that have some mild treatment, some mild disease, and they have many things to look at. We have to look of the metabolic thing, if everything is all right, how is dietary factors, that something is wrong about that. We have to look at depression, anxiety, and we have to look at the somatosensorial thing. So we have, the question is the subtyping, but I believe drugs may help in some way in all patients, except for maybe the very, 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 very complicated patient, the one that has gone everywhere and has taken everything. This is a very difficult patient to try. And I think these patients may go on to acoustic therapies or to the CBT also, but they are very complicated patients to try. We have to think of subtyping tinnitus and then a multi-approach strategy of treatment. That's what I believe.
Thank you very much. I have some points to share, then we have some few questions focused mainly on pharmacotherapy and other treatment modalities. So let me to share with you a few points from my experience. I do use propranolol or Inderal for the vascular tinnitus. So sometimes if no surgery can be done, if no other intervention can be done, sometimes I use Inderal, and it decreases the pulsations. If you have, because Inderal causes some sort of vasoconstriction. So it decreases sometimes the pulsation. It works in some conditions, high arched jugular bulb or apparent carotid artery, or with anxiety. When you have this one, sometimes it works. But it causes depression. So it's avoid using it at the bedtime. It causes nightmares. And usually I use 10 milligrams twice daily, excluding the night dose. Regarding the clonazepam, it's a controlled medication in our region, and it's a highly dependent drug. It's a Rivotril. It's called the Rivotril, produced by Roche company, and as I remember, and it's a very addicting drug. So I'm not sure if it's very effective. I know it works in epilepsy, it works in like anxiety, insomnia. It can work for myoclonus very well, but for like subjective tinnitus, I'm not sure, but in our region, it's a highly controlled medication. It's a very addictive medication. So we don't prescribe, and it seems hard to include in our protocols. For the tensor tympani myoclonus, also for the same reason, we prefer using sodium valproate or valproic acid or dipakine, because this is not controlled doesn't make a dependence or addiction. Regarding the Jinko, like 10 years ago, I was very advocate to the Jinko because I like the story of the Jinko tree, Jinko Biloba tree in Japan or China after the nuclear bombing. So it is the only plant which survived in Hiroshima and Nagasaki after the nuclear bombing. So I was very excited, and the pharmaceutical drugs have been promoted. But with the lack of evidence, I observe it. It's very frequently prescribed medication in our region, and frequently to be combined with ginseng. I observe that the patient is taking, especially the combination of Jinko Biloba and ginseng, they have more insomnia. Those are drugs which causes some activity and arousal. So if the patient has insomnia, I don't recommend the use of Jinko or ginseng containing compounds, because in my experience, they increase the insomnia, irritability, and sometimes the anxiety. I do use melatonin. It's a very nice medication, but not available all the time. But sometimes it's sold online, or people bring it from United States. It's OTC drug in the United States and Canada. You don't have a prescription. It's commonly used for the jet lag, but I have it myself. So sometimes we recommend it. It helps insomnia, and it's a very good choice. Somatriptan works also with the same. It has a vasoconstrictor characters or actions. So it could, yes, decrease pulsations, but for me, I prefer the Inderal or propranolol rather than using the somatriptan, the migraine drug. So those are just some few points from our experience. So let's say to go to the question. Regarding the lidocaine, how you use intratympanic or what? How you use the lidocaine? Because we have some studies in Egypt, they proposed intratympanic lidocaine as a line of therapy. So what's your comment, Dr. Ricardo?
No, I don't do the lidocaine test. I don't do it. And I am not aware of the intratympanic effects of lidocaine. It could be very interesting because we know that it helps many times, but we still have to find how we could treat patients with it.
Yes, audience asking if you can share your email. Some of
yes, I did.
Our colleagues is interested to know more about the clonazepam. But I would also remind with my warnings regarding the high addiction rates. You agree or no, Dr. Ricardo?
What? Say it again.
The addiction potentiality of clonazepam, dependence and addiction.
Yes. There is also a controlled drug here, but it's easy to find. And what I do is to use the drop formulation to take it out, one drop each week. And so
what is the concentration of the drops? What is the concentration?
Oh, it's one drop, 0.1 milligram. So I start with 5 drops. And then I use it for 3 months. And then I started to take 1 drop a week. Okay. To downscale. So I don't have that much problem of dependence. The big problem with clonazepam is a very it's available. So most of the patients already have taken clonazepam for that reason or other reasons. So it's hard to find a patient that has not been on clonazepam as yet. But when the patient never took it and we started, it may help many patients. But I start to take it off with the drops.
Okay, that's perfect. So also can you highlight how you treat the tensor tympani myoclonus? if just highlight or elaborate more on treatment of tensor tympani myoclonus, and if you use Botox or botulinum toxin injection, especially for the tensor villi palatini myoclonus, it's more common to be used in the tensor villi palatini myoclonus. So if you have any experience of the Botox or botulinum toxin injections, highlight, share your experience, and give more clarification on the treatment of tensor tympani myoclonus.
We personally don't have much cases of tonic sensor syndrome here in our city. I don't know if Sandra has, maybe, but we had some palatal myoclonus back, and patients got well again with clonazepam, but I have no experience of the botulinum toxin. I don't know, Sandra, do you have some?
No, I don't.
We don't.
Yes, actually, I don't see many patients. Like I saw, like in the past, a very interesting case. Like I was like in the beginning of my work as ENT, and the patient had a long time ago that he had a myoclonus palatus, and that was like something that was like amazing, and it was objective. We could like hear his tinnitus, and it was like a dramatic case. I don't really like remember what we did at that time, but I don't know. I don't remember if he went to surgery to have those muscles, because as far as I remember, he didn't improve with medication, with the mu relaxant medication. It was very, very severe, very dramatic case.
You mentioned, thank you very much, Sandra. You mentioned, Ricardo, something about a centrally acting muscle relaxants, maybe for also the myoclonus, or maybe for the tensor tympani also. You have clinical experience with this? Because this is...
Cyclobenzoprine.
You know which company produced it, or what is the trade name of it?
Cyclobenzoprine, it's very... No,
Miozan.
It's a Brazilian company. I don't know the international.
There is few centrally acting muscle relaxants. They cause sedation, but you have clinical experience that they can relieve tensor tympani myoclonus, or can help. We have one of the questions: if the tinnitus get modulated by the muscle activities, like any muscle activity in the head region, or like upper part of the body. Sometimes this is increased loudness of tinnitus. So could be using muscle relaxants, could be of help in those cases or no?
I don't know. What we have been using the cyclobenzaprine for general tinnitus, and it sometimes work. We don't know if this is because the sedation or the neurochemistry involved, but it sometimes work. But concerning tonic tension tympani, as I told you, I don't know exactly where. We don't have that much cases here in our city.
It do exist, like tensor villi palatini is not very common, but tensor tympani myoclonus is common, and sometimes associated with noise-induced sensory neural hearing loss. So if you dig in the clinical interview or the clinical history, sometimes you have a combined tinnitus. So there is subjective tinnitus, and with attacks of clicking sounds on. We have, because I work in a military hospital, so I have a lot of noise-induced tinnitus cases. So I found it's not uncommon to have tensor tympani myoclonus superimposing a chronic subjective tinnitus. So that's in our experience. Maybe because of just I work in a military hospital, so I see a lot of those patients. I think we have a great discussion, great presentation. This is for me. I have learned a lot, honestly. I congratulate you for this wonderful presentation, this valuable input, this high quality research and clinical expertise. I enjoyed really the full course, the discussion and everything. And you raised to our attention many new points, which will be looking more in depth about it. So it has been a great pleasure and honor to have you. You did a great job. We are very proud of you. And honestly, I don't say it's a compliment. Personally, as interested in tinnitus and running a tinnitus clinic, you enriched my insight. You taught me many new things. You gave very valuable information. We will be looking for more, to know more about this information. Most likely we'll contact you. If we have more questions. And I think all of you in our Facebook group, so if any audience wants to send a message or to ask direct questions for you, fortunately, all of you are members in our Facebook community, and thank you for this. If you want to say something to the audience, please go and say something for the audience before we close the session.
I talk too much. No, I want to thank you for all of you that for like watching us and listening to us. It was a very good pleasure. It's meeting you, Dr. Mohamad, especially, and I hope to see you soon.
Thank you very much.
Everybody else together.
Okay.
Ricardo, say something.
Thank you very much. It was an honor and a pleasure to be here. I would like to congratulate you once more for this fantastic group, and I hope that everything goes well in the world and that we can meet personally in the very near future. Thank you all.
Hope so. Sheila, please say something.
Thank you for the opportunity. Thank you, Dr. Alfarghal. Thank you, colegas aqui do Brasil, né? Thank you, doctors. And very pleasure. I am here and learn from all of you. Thanks.
Thank you. Dr. Andrea, let me to tell the audience that Dr. Andrea is the wife of Dr. Ricardo. So we have a high-level couple in the tinnitus services. So please say something.
Together here.
Yeah.
Thank you very much. It was an honor for me. Hope to see you all soon. Not internet anymore, but to really see. Everybody stay safe. Thank you very much.
Thank you very much. Thanks to all of you. Thanks for the audience. And by this, we close the session. Stay safe for everybody, and please, thank you very much.
Thank you. Bye-bye.
Bye.